هي معقولة.
معقول إن إحنا نتقابل باللينك الغلط؟
وأنا كمان حاسة هيك. لا أنا امبارح بعتت هي.
لا، هيدا هو اللي بعته. لا.
بتصور بعتت امبارح إيميلين.
هات لنشوف. ايه.
Good morning.
Everyone. Hi, doctor. How are you?
So I'm going to make you a host,
Okay, perfect.
and you see, Ala, you'll see the breakout room when I make you the host.
Okay.
I can
I
assign
was thinking that maybe we can start with like a small recap on bias, and then
it's up to
yes.
you. But let me know when do you want me to assign them into breakout room based on their.
Okay. Okay, maybe around 10:15. Okay.
10:15. You let me know. I'm working. I might not be all the time
okay.
attentive, but you can send me a note.
Okay, great.
So,
we can start if you want.
Yes, you're a co-host.
Okay. Can you see my screen?
Yes.
Okay, perfect. So actually, good morning, everyone. Today is our third and last session. And as we agreed last time, we're going to go over the biases in epidemiology. At first, I thought it would be more like a practical session, discussion of articles. But after discussing it with Dr. Shaya, I thought it would be nice to start with a small recap or overview, or maybe like you will learn like new things about biases before going to article discussion and practical exercise. So that's why we're going a little bit to shift the flow of the session. I'm going to start with a small lecture, and then we will do the breakout room and discuss the articles. Okay. So let's start. For the biases, the outline of this presentation. So I know that you're more or less familiar with the concept. You've taken some of them in your in the basics EPIs, APHD 300. But what I'm going to try to do today is to go over what you already learned and maybe just add some additional information just to know so that you can feel comfortable with the concept of biases. So we're going to do a recap about what is the definition of bias, what are the types of biases. We have the selection, information, and confounding bias. And then we're going to discuss some example of biases in different types of study design, because as you're going to see, you have some bias that are basically you can find in all observational study, in cross-sectional studies, and you have other biases that are very specific to a certain type of study design. For example, loss to follow-up is very specific to cohort study. Bergson bias is very specific to case control study. So you're going to see that there are some biases that are that you can find in all type of observational studies, and other that are more specific to a certain type of study designs. And finally, if we have time, we're going to do the application. I'm going to give you some articles and you're going to discuss it, and you're going to be divided into groups and discuss the methods to see what are the potential biases in the methods of the article. Okay, I always like to start by the reference that I used, and I really think it's nice for you as master student to have as a reference that you can go back to it later on. So for example, for the DAGs, I really insisted that you know about DAGITY because it will be very helpful for you. And same thing for the bias. I really advise you, I'm going to post this article on Moodle, but I really advise you to read it and to keep it with you when you're going to do any kind of a study, because it really explains very well the biases and the different types of biases according to the study design. So it's like, it's really my reference book when it comes to bias, and I've based most of the presentation on this article. And what is nice about this article, so it is written by Delgado Rodriguez. It was published in 2004, but you have very big and very nice table about all the types of biases. What are there information or selection bias, and in which type of design you can find it, so that in a case control, in a cohort, in observational, etc. So that's a very, very nice article and very clear article that I would definitely advise you to read if you want to know more about bias. Okay, so let's start. As usual, it's going to be an interactive presentation, so I really want you to participate. I know that you might know a lot of the answers and others that are, maybe you can guess. So the first one is like a recap. So what is the difference between random error and bias? Can someone answer?
The random error happens by chance, but the bias is systematically.
Yes, so that's
Systematic error. Yes.
Yes, exactly. That's the basics of biases when we talk about EP. So random error, we also call it lack of precision. As you just said, it's a portion of variation in the measurements that has no apparent connection to any source. And we usually consider it as due to chance. And so it adds variability, but it does not affect the mean of the group. So like a nice illustration of random error would be, here you have to, it would be accurate, but not precise. So the points would not be next to each other, but there would be, the mean would be basically correct, accurate in the center. And if we want to see it in this graph, if we see that the blue is the truth, the green would be due to, so would be the consequence of random error. So the average of, if we see the green curve, the average is the same as the blue one, so the truth. However, the variation is, you can see that the random error will add variability around the average. So you see the curve, it's larger if you want than the blue one. And as you just said, bias, it's a systematic error. We have a recognizable source, whereas in random error, we don't really have an apparent source. For example, a recognizable source, when we talk about, for example, a scale, a measuring scale that always gives 2 kilograms, additional 2 kilograms to each person. So in this case, it is consistent, it is wrong, and it's always in a particular direction. So the way we illustrate systematic error, we say that it's precise, so the points are next to each other, but it's not accurate. And in this graph, as you can see, so the blue is the truth, and the red curve is a consequence of systematic error. We can see that the mean is very far from the truth, but we can see that it's still precise. So we have so it does not affect the average. So it does affect the average, but we can see that the variability is not really affected. So this is like a quick recap of difference between random error and bias. So now I'm going to ask you, if we have random error in our health research, how can I basically decrease this random error? What are the ways that I can use to decrease a random error?
Increase sample size.
Perfect, that's it. So usually when you have random error, the way to decrease it is by increasing sample size. Of course, we cannot eliminate the random error, but we can estimate it. That's why we talk about p-value or confidence interval. So what really p-value means is that when I'm saying that I have a p-value of less than 0.05, it means that the probability that I have a just 5% probability that my results are equal or like this or more extreme, due to chance. So this is it. So basically, when I talk about p-value, it's a way about talking about the probability of having this result due to chance. So as you said, the way to decrease random error is by increasing sample size. So now let's go to biases. What are the types or the categories of biases? We know that, source of error in epidemiological research, you have the random error and you have the systematic error. And among the systematic error, you have selection bias, you have information bias, and you have confounding. I'm not going to talk about confounding. We talked about it a lot when we talk about DAGs. So I'm going just to focus on selection and information. But just to continue in this, with this slide. So when we talk about error in health research, we talked about random error, and we said that the way to decrease it is by increasing sample size. Now for systematic errors, we have the confounding bias, and the method to decrease confounding bias, we already discussed it last time. It's basically when you talk about stratification, when you talk about restriction, about matching, or randomization in case we can do an RCT. Okay, so let's move now to the other two systematic errors, which are selection bias and information bias. Selection bias, so who can actually remind us what is selection bias? can someone give a kind of a definition of selection bias?
It's when we have in the recruitment of subjects.
When we have, sorry, I didn't hear.
When we have an issue in the recruitment of subjects, or
Yeah.
the groups are not comparable, or lost to follow up actually do not have different characteristics than those who stayed in the study.
Exactly. So basically, it's how we are selecting our subjects. So what you said is that those who are selected. So when we have a systematic difference between the characteristic of those selected for the study and those who are not. So in other words, if my sample size, my study population is different than the target population when it comes to the exposure and the outcome. And this would definitely impact the association between my exposure and my health outcome. So we all agree, like Ken, about selection bias. So in other words, it's when the way I'm selecting my population is not representative of the target population when it comes to exposure and outcome. If you want another illustration, just to clarify the idea. So we have, let's say here, we have the target population, which is IV drug users in the US. This is a big yellow circle. Then I have my small circle, I'm gonna say brown circle, which corresponds to the source population. So it's the IV drug users seen at hospital, clinics, and other healthcare facilities in the US. Because if my target population is the IV drug users in the US, my source population would be, I will actually recruit them from hospitals and clinics and healthcare facilities. And then I have the eligible population, which is a small circle. The eligible population would basically represent the random, so it's my sampling frame if you want. So I would select a random sample of IV drug users seen at, for example, 9 randomly selected hospitals and clinics during 12 consecutive months. So this is my eligible population. And then from this eligible population, I'll have the small circle, which will be my study participant. And it will be the participants who are eligible and agree to participate. So you can see the difference between the target population and this small circle, which correspond to my study participant. And what I really want at the end of the day is that the distribution of my exposure and my outcome in my study participants in the small circle would be basically the same that in the target population. It would reflect the same representation, the same distribution. And for this, this is a nice illustration of the concept of selection probabilities. So if you see this illustration, we have the green square is a population base or the target population, the general population. And the light green would be my study sample or my study population. And what I really want is basically, we have the exposed and the non-exposed, and I have the case and control or disease and non-disease. I want that the selection probability for each of these cases is equal, because I want that the study population would include equal proportion from each cell. So it doesn't mean that I will have the same number, but I'm talking about the probability of selection. So the probability of selecting my participant from each cell should be the same to reflect the real distribution in my target population. Is that clear? So if I have 20% of smokers with lung cancer, I should have in my study samples the same percentage. Okay, I'm gonna just, continue. So if we go back to this very famous dichotomous table that we usually use, so we have exposed and non-exposed, and we have disease and non-disease, and we have the ABCD. So my odds ratio, if you remember, it will be equal to A over B over C over D, which is, if you want mathematically, it's A by D over B by C. So when we have any kind of difference or discrepancies in my selection probability in any of these cells, so as you can see here in illustration. So for example, if the selection probability of the control and not exposed is lower, it will affect my odds ratio. I will have a biased odds ratio. So for example, in the first case scenario here, we can see that the probability of selecting not exposed and non-disease is lower. So we have an underestimation. In that case, how it would affect the odds ratio, it's like D would be decreased and my odds ratio would be decreased. So I will have an underestimation of my odds ratio. Is it clear so far?
Yes.
Yes.
Okay.
Yes, it's clear.
Okay, great. And same thing for all the other case scenarios. So it depends of how of my selection probability. So let's now, this was very theoretical. So let's now give names to this kind of selection bias. What I want you to do now is try to remember what you have learned about selection bias and tell me, what do you remember? What are the type of selection bias? If you remember what we can find selection bias in kind of cross-sectional studies of all kinds of observational studies, or if you remember what are the type of selection bias that are specific to case control or to cohort. If you know, try to just participate, and if you don't, try to guess. What do you remember about type of selection bias? Or what could cause selection bias?
Sometimes non-respondent.
Perfect, that's one. So non-response bias is a selection bias. So people who basically accept to participate in your study are different than those who don't accept to participate. And this would create a selection bias because maybe the characteristic of those who participate are different than those who don't. That's correct. Do you have other types?
Loss to follow up.
Perfect. Loss to follow up for cohort. So it's the same idea. It's a selection bias. So people who decide to stay in the study might be different than those who decide to stop the study. It could be related to the exposure or the outcome. So they started having some symptoms and they decided to stop participating in the cohort, and maybe later on they will develop the disease. So it will be a selection bias. Correct.
We have also in case control misclassification.
Referral bias.
Yes, and misclassification. Okay, so misclassification, do you think it's a selection or an information bias? It could be, we're going to...
case, for example, and we consider it as a control.
Yes. If it's a case, so you mean the way you ascertainment is different. Yes,
exactly.
That's correct.
Yeah,
yes, that's totally correct. Yes, that's totally correct. So you basically said most of them. So you said the non-response bias, which we can find in all type of studies. Or also we have, I'm sure you know about the volunteer bias or healthy volunteer bias, that usually people who tend to participate when let's say I'm doing I'm doing a study and I want to recruit a convenient sample. So just going to give you an example. I want to see the association between obesity and depression, and I don't have time. So I'm just, I want a convenient sample. I do flyers, I put them on the FHS, asking for volunteers to participate in my study. So most probably people who are going to volunteer to participate are maybe healthier people or non-obese people. So I would have an underrepresentation of obese people in my study sample. And that would be a consequence of the healthy volunteer bias, that people who volunteer are more or less usually healthier. Neyman bias, I don't know if you know about it, but we're going to discuss it now. So Neyman bias or incident prevalence bias are the same thing. We call it incident prevalence when we talk about case control. Otherwise, we call it Neyman bias. What you already said, it was ascertainment bias or detection bias. So when the way I'm actually selecting my case and control I have a bias in the way I'm selecting my case and control. I'm going to talk about it later on. We have something called Bergson bias. I don't know if you're familiar with it, but it's very common in case control when we use hospital patients, and I'm going to give an example about it. Cohort, you said about loss to follow up. I'm sure you know about the healthy worker bias when you talk about occupational study that are basically very common in retrospective cohort study. So it's the same idea that we usually, when we have occupational study, we would recruit, we will recruit or we are going to do a retrospective cohort study. Those participants are healthy worker, and this will definitely bias my estimate, my effect estimate. And we have something called competing risk also. So when we talk about cohort, it's very important to see what could be other exposure or other variable that could affect my outcome and that might basically compete with my main outcome. I'm going to give example because this now is very theoretical. Now, of course, these are not the only biases. If you go back to the article, there are so many other biases. Someone told me about referral bias, reporting. There are so many different types of biases. I just wanted to focus on the most common ones for this presentation. But definitely, you can find all the others in the article. And if you have any question about it, you can tell me. Before delving into selection bias and talk about each of them, I'm just going to very quickly talk about the second type, which is the information bias. For you to know that information bias, we have several subtypes. We have misclassification bias. We have something called ecology fallacy and regression to the mean. I'm not going to talk about the other two. We're just going to focus on the misclassification bias, which is the most common one. And the most, usually we really, when you talk about information bias, most of the time we talk about misclassification bias. So as you said, misclassification bias is when we have a bias, so it says when sensitivity and or specificity of the procedure to detect the exposure or the outcome is not perfect. So I will have an exposed and diseased subjects that can be classified as non-exposed or non-diseased and vice versa. Or I can have like a non-exposed disease that will be classified as exposed disease. So when I will have any kind of misclassification in my dichotomous table. And when it occurs, information bias, it occurs at the stage of data collection, which makes sense because it's when I'm collecting my data that I can have information bias. So let's do the same exercise for information bias, but just focusing on the misclassification bias. Do you know, so what do you remember about types of information bias?
I think recall bias.
Perfect, recall bias that are very specific in what type of studies, are very common in what type of studies usually?
And cross-sectional and case control.
It's in both, but specifically in case control. So what else do you remember? What else do you think we can have now? I already added a few of them, but if you have other...
We have reporting bias.
Reporting bias, yes. What else? If I'm talking about, for example,
bias.
What?
Confirmation bias.
Confirmation bias, okay.
I think one.
So I didn't hear.
I said we have recall bias.
Yes, so recall bias, as one of your colleagues just said, or your classmate just said, it is indeed an information bias. It's very, you usually find it, or usually see it in case control studies. We can also see it in observational and cross-sectional studies. Okay, so we have also, as you said, reporting bias or social desirability bias. And this is basically when it comes to the subject. So let's say I'm doing an interview about alcohol and the subject doesn't really want to tell me the truth because, I mean, he find that, okay, he doesn't want to tell me the real consumption of alcohol and he might give me the answer that I want to hear. And this is what you call social desirability bias or reporting bias. Interviewer bias is the opposite. It's when me as an interviewer, let's say that I'm doing I'm trying to retrieve data, I'm doing a questionnaire with subjects about, so it's a case control, and I'm studying the association of smoking with lung cancer. So I'm doing an interview with a person that I know has lung cancer, and maybe I would probe more the questions related to smoking. Maybe I would insist more on having information of smoking. I would try to, kind of stress on these questions because, in the back of my mind, I know that he has lung cancer and that I know that it could be linked to cigarette smoking. So I will try to probe differently or to more thoroughly everything related to a smoking section, to the questionnaire about smoking section for this individual. And in that case, it's a bias because I'm basically having this a priori knowledge that this person has lung cancer. And the best way to remove this kind of bias is basically by blinding the interviewer. So if I'm doing an interview and I don't know if this person is a case or is a control, I would ask all the questions the same way. But if I know that this person is, for example, a case, it might change the way I probe for certain questions. That makes sense? So that's when we talk about interviewers.
Yes. I just have like a thought or a comment.
Yeah, sure.
Yes. When we talked about the DAGs last week, so
Yeah.
I thought it might imply some kind of bias in the design of the study, because if theoretically if I know that I will be only interested in one variable when I am drawing my DAGs, so I will focus on this variable more than other variables, which might lead to some kind of bias that is similar to the case control one.
So you mean when you are designing, if I understood correctly, I'm just going to rephrase the question just to make sure that I understood what you mean. So let's say that you're drawing your DAGs and you saw the covariates that are of interest. And when you are going to design your questionnaire, you just want to focus on the variables that are of interest, right?
Yes.
But this is not really a bias because basically you are focusing on collecting the information of these variables across all your study participants without having a bias of those who are exposed or non-exposed. So you want to collect this information, let's say smoking, across all your study population, and that's good because you need this variable and you need to collect it this variable in a very thorough way across all your study population. When we talk about interviewer bias, it's when it differs between one group and another. When the way you deal with the case is different than the way you deal with the control, or when the way you deal with the exposed is different than the way you deal with the unexposed.
Lana, I thought, when we draw the DAGs, and then we design our questionnaire that we collect data about all variables, but at the analysis we just account for the variables that we draw in the DAGs. And that was my understanding. So I thought that the researcher will be more interested, or he will try to measure the variables that shown or that were associated in the DAGs more accurately than other variables in the questionnaire. That was my thought.
Okay, I understand what you mean, but there are two different things. Now, if you have to, do you want to collect information on all the variables or just on the variables that are of interest is something. And the second point, that it doesn't matter if it's the same way across all the study population, because at the end of the day, you need this data. You need to have it. You need to have the information. You have to have accurate information, but you need to have it consistently across all your study population. And that is the main thing that you need to think about when we talk about bias. It's you need to have, so when we talk about bias, it means that we have something that is not consistent across your study population. You treat one group different than another group, which will create a bias.
Okay. Yes.
Okay, so when you are basically making sure and you're conscientious and making sure that this variable, you are collecting it across all your study population, that's not a bias. You're just basically collecting the information in a thorough way across all your study population. But if the way you are collecting this information would differ based on the participant, whether he has a disease or whether he's a case or control, or whether you know that he's a smoker or non-smoker, that would create a bias. Now, for the first part about what you need to collect, when you are designing your questionnaire, of course, you're going to put a section that are related to the variables that are of interest, and the one that you would need for your analysis. So definitely that would be the main focus of your questionnaire, because it's useless to collect information that you would not use. Of course, it's better to collect those that are available in your DAGs as a safety net to have this information. You never know, maybe you would need them later on, but you have to make sure that the most important variables are in your questionnaire to avoid having, unobserved or unmeasured variable in your DAG.
Yeah,
So
thank you. Yes. Yeah, thank you so much, Krista. It's clear.
Okay, great. We already talked about recall bias, and now I'm going also to later on talk about the difference between recall bias and poor recall. And we have the exposure suspicion bias, which is linked to recall bias, and I'm going to give an example. So everything that is in this table that you don't know, don't worry, we're going to talk about it later on. And then for the cohort, we have something called detection bias, or diagnosis suspicion bias, or surveillance bias. And as you can see, detection bias in a case control is a selection bias. Detection bias in a cohort is an information bias. And I'm going to clarify this concept later on, but just for you to keep this in mind. I mean, it's very common sense because it depends if your outcome is the selection criteria or not. So let's start with selection bias. The non-response and the healthy volunteer bias, we already are familiar with this concept. I'm not going to delve into it. I give you the example of, for example, okay, the same thing. If we talk, I'm doing about child obesity, a study about child obesity, and so about dietary intake and child obesity, and I'm doing a study in schools across Lebanon. I might have more non-responsive parents of obese child would maybe prefer or be more reluctant than their child participate in the study because it's about obesity and there is some stigma around it. And I would end up in my study population. So let's say that the target population have 30% of child who are obese, but in my study population, I only have 10% because I do have a high rate of non-response. A lot of obese children did not agree to participate in my study. So that would be a non-response bias. Okay, so that's the healthy volunteer and non-response bias, which I think are very clear concept to you. So let's move to the Neyman bias or the incident prevalence bias. Before is it clear the non-response bias and the healthy volunteer bias these are clear concepts for you, or do you want me to delve into it more?
Yeah, yes, it's clear.
Okay, so let's go to Neyman bias, or when we talk about case control, it is called incident or prevalent cases. In your opinion, when we are doing case control, is it better to take cases that are incidents or are recently diagnosed, or prevalent cases, so cases that have it's been a while that were diagnosed? Let's say that I'm doing case control about
incident cases to avoid recall bias.
Okay, incident case.
Yeah.
That's someone else has another suggestion. Okay, well, that's correct. The incident case is correct. And it's true that it's better for the recall bias, but also you can see it from a different approach. So as you just said, it's correct. When we talk about case control, it's always better to have incident and prevalence case. And I'm going to give an illustration, but the reason is different than the recall bias. So recall bias is one of the reasons, but it's when we think about it as an information bias, that people incident would basically remember better than the prevalent cases. But also if you want to see from a selection perspective, I'm going to give you an illustration that would clarify the idea. So let's say that you have a case control study is carried out to study the relation between tobacco smoking and acute myocardial infarction. So the cases were interviewed 1 week after the coronary attack. So after 1 week, we did the interview. But let's suppose that smoker patient with myocardial infarction die more frequently on average after 2 days than non-smoker patient. So this is
Cutting off,
just an illustration.
Christelle,
Okay.
Christelle, it
Yes.
was not at all clear, the example, because you were cutting off.
Okay. I'm gonna repeat the example. So let's say, are you being able to hear me now?
Yes, now yes.
Okay. So let's say that you have a case control study, okay, to study the relation between tobacco smoking and acute myocardial infarction. And let's say that cases were interviewed 1 week after the coronary attack. And let's suppose that smoker patients with myocardial infarction die more frequently, so on average after 2 days than non-smoker patients. So in your opinion, how this will affect my estimates? So basically, people who are smokers will die after 2 days, and I will do my interview after 1 week. And let's say that my exposure is smoking, because this is, my exposure is tobacco smoking, and my outcome is myocardial infarction.
Yeah, this will underestimate the relation in the smoke.
Perfect. That's it. So the fact that, so the people who are basically dying or leaving, they will show lower frequency of smoking. So we will have an underestimation of the association between smoking and myocardial infarction. So if you want an illustration, that I like illustration in biases because it really clarify everything. So this cell, which is exposed and cases, it will be an underestimation because most of them died, let's say. They died after 2 days. So those who remained are people who are not smokers. So I will have an underrepresentation of smokers. And in this case, the A, which is the case A, is an underrepresentation. So my odds ratio would be an underestimation. So that's another reason why we usually like to take incident cases in bias. So as you said, recall bias is definitely a reason, but also another reason, it depends. I mean, it's not in all case control studies. It's when your exposure and basically, like in this example, so you have people with who are like, let's say, smokers have more tendency to die, let's say, from myocardial infarction. So in my case, I would have an underrepresentation of smokers. So that's another reason why in some cases, for case control studies, I prefer to take incident cases rather than prevalent cases. And that would be a selection bias. Is it clear?
Yes.
Yes.
Okay, perfect. So we talked about Neyman and incident. Now let's talk about Bergson bias. This is a bias that I like a lot because it's actually quite common. And even in the COVID-19 studies now, you're going to see a lot of articles talking about how several studies on COVID-19, for example, we had at a certain point people saying that smoking was protective against COVID-19. And it turned out that it was a Bergson bias, because people or researchers were sampling older population from hospitals. So let's think about what could be the issue in sampling when we have a case control, in sampling the case and the control from hospital. So Bergson bias is a selection bias that actually arises when the sample is taken not from the general population, but from a subpopulation such as hospital patients. So let's do an illustration. So we have Saketata, the author. He looked at the association between locomotor disease and respiratory disease. So he conducted the analysis on 2 data sets. First, he conducted the analysis on the general population. He recruited 2,784 people. And then he had, so he did the dichotomous table, exposure, respiratory disease, yes and no, and locomotor disease or disease of bones and organ movement, yes and no. And he computed the odds ratio, he got 1.06. which means that we don't have an association between respiratory disease and bone and organ of, and disease of bones and organ, or locomotor disease. Then what he did, he did the same analysis on patients from the hospitals. So he basically recruited 257 patients from hospital, and he computed the relative odds ratio, and he got 4.06. So it's a huge overestimation than in the general population. So when we just look at this subpopulation of people who were in the hospital in the prior 6 months, we see that there is a link between respiratory disease and locomotor disease, as if respiratory disease would increase by 4 times the risk of having, or the odds of having locomotor disease. And then when he looked closely, he discovered that actually the reason for this bias is, can someone guess what could be the reason?
Yeah, people, participants from the hospital, most likely to have diseases, for example, like respiratory disease.
Yes, to have those both disease.
Which is not representative for the whole population.
Exactly, perfect. So that's exactly the reason, because if we look at people with respiratory disease and with locomotor disease, in the general population, 7.6%. If we look, so 17 out of 2,583, it's 7.6%. However, in the hospital, because in the hospital, it's more likely to have people who are sick. It's more likely to have people with diseases in the hospital. So the probability to have people with respiratory disease and locomotor disease is way higher. It's 25%. So that's why our sample in the hospital was not representative of the general population. And usually we talk about Bergson bias when we know that my outcome or my exposure are linked to hospitalization. If my exposure, for example, here it's respiratory disease, it is linked to hospitalization. And my outcome here, it's locomotor disease, is also linked to hospitalization. If you have bone or an organ of movement, and disease of bones and organ of movement, I will more likely be hospitalized. Same thing for respiratory disease. So both my outcome and my exposure are linked to hospitalization. In my hospital patient, I will have a higher percentage of people with respiratory disease and with locomotor disease. So here I will have an overrepresentation of this population, and it will definitely bias my my effect estimates or my odds ratio. So this is the representation. The first set of exposed and cases, so let's say respiratory disease and locomotor disease would be an overestimation, and I will have an overestimation of odds ratio. So as I said, people are more likely to be hospitalized if they have 2 diseases rather than only 1. So I have a higher exposure rate among hospital patients as compared to the general population. And so my odds ratio will be biased. It will be an overestimation. So that's a Bergson bias, usually when we talk about hospital patients. And I'm going to put on Moodle an article talking about COVID-19 research, how people were basically taking case and control from the hospital and how they had biased estimate, and especially how they had some article were showing a protective effect of smoking on COVID, but basically it was a Bergson bias. Okay, so just take another illustration. Now, when someone asks me about DAGs now, there is a way we can look at the Bergson bias from a DAGs perspective. I'm gonna, because this is not really the point or the focus of presentation. I'm not going to talk about it now if you want. Okay, so okay, are you being able to hear me now? Because I thought
you were cutting for a bit.
Okay. But is it clear, the Bergson bias, is it clear as a concept? So it's basically when we have hospital and when we have patients from hospital and when the exposure and the outcome are associated with hospitalization. Okay, is it clear?
Yes.
Yes.
Okay. So now let's move to the detection bias as a selection bias in case control studies. And then I will just quickly link it how the detection bias will be an information bias in a cohort study. Women who use estrogen are more likely to bleed. This is a side effect of estrogen.
Christelle, you're cutting off a lot. Christelle.
Yes.
Can't hear you. I think you need to repeat from the beginning. Sorry.
Okay, I'm just. Okay, I don't know why, because I have a good connection here. I'm gonna try again. Okay. So now are you hearing me?
Yeah.
Okay.
Yes.
Okay, so when we talk about connection, I don't want a case scenario. This is a case scenario. Let's say that I have a case control that is conducted to test if estrogen are a risk factor for cervical cancer, okay? The cases are selected from the hospital. Now, this is known that in women who use estrogen are more likely to bleed, which is a side effect of estrogen. And people, women who are bleeding are more likely to go and do follow-up at their doctors, which makes sense. And when they go more frequently at their doctor to do follow-up, they are more likely to be offered screening for cervical cancer because of bleeding. So in this case, women who are bleeding due to estrogen as a side effect of estrogen are more likely to be offered screening for cervical cancer. And logically, they are more likely, because they are screened more frequently, they are more likely to actually be detected. In this case, the use of estrogen may cause a surge for cervical cancer by causing patients without symptoms to actually bleed, rather than causing the cancer itself. So in this case, estrogen did not cause a cancer, but estrogen caused a bleeding, and bleeding caused women to go more frequently at their doctor and to do more frequent screening. And when they are doing more frequent screening, the chance of detecting cervical cancer, of course, is increased. So in this case, what happens is that we have a higher probability of being detected when we use estrogen. So people who are exposed, so let's say that estrogen is my exposure and cervical cancer is my outcome. So people who are exposed, people who are taking estrogen, we have a higher likelihood to be diagnosed with cervical cancer. So the first cell, which is exposure and cervical cancer and disease, is going to be an overrepresentation of the general population. And in this case, my odds ratio is going to be an overestimation. Here, it's not that estrogen causes cervical cancer, but estrogen causes a symptom that increases the detection of cervical cancer. And this is why we call it detection bias. And more specifically, in this case, we call it an unmasking detection or signal bias, because it's a signal bias. It unmasks. So that is one, if you want, subgroup of the detection bias, when the exposure basically would cause a symptom that would increase the detection of your outcome. But in this case, it doesn't mean that this exposure is the cause of the outcome. It just caused a symptom that would increase the likelihood of you going and doing some screening to be detected as, and be detected as having cervical cancer. Is it clear?
Yes, but in this case, for example, if we consider screening as a confounding and we account for it, will the problem be solved?
Now here, because we're talking about case control, we're talking about selecting individuals. So the way I'm selecting my case, I'm taking people from the hospital who are going for cervical screening for cervical cancer. And people who are going for screening and who are basically being offered screening for cervical cancer happen to be people who are taking, and we have a higher likelihood of people who are taking estrogen. But when you talk about confounding, I didn't really understand how are you, because here we're not talking about confounding, we're talking about selecting participants. So it is from the very early stage of the study. If you can just clarify what do you mean by confounding? Because here we're not, it's not taking when we have the variable and know, are they screened or not? This is how I'm actually selecting my population, my case.
Yeah, I understand. But in this case, people taking people who are going to the doctor are doing more screening, so more detection.
Yes.
Right? That's our case. So if we do make a screening is like a confounding for all, so maybe we can solve this bias, this over detection. That's how I thought about it.
So you mean here the way to basically avoid this is so you're talking whether we have in the controls, so the people who are not, so the controls, you see who did the screening or not. This is what you mean?
Yeah, for example, if among the controls and among the cases, equal proportion of screening. Yeah.
Okay, but you're still not solving the problem, because the problem is that the estrogen said that people with estrogen, okay, so the problem is the exposure, that people with estrogen are going to be higher in your sample. So it's not about adjusting for screening. It's about that people with estrogen they will have a higher likelihood to be diagnosed because they have bleeding. And not because it's a cause. So you cannot adjust for estrogen because it's your exposure. So the thing is your exposure, it's not the screening per se. It's the fact that the exposure they have, which is estrogen, is going to increase the likelihood to be detected and to be detected or to be classified as case. So your if you want, your issue is in here. I hope it's not my voice. Okay.
Yeah.
So it's estrogen. That is, you cannot adjust for because it's your exposure.
Yeah, it's
yes. Okay. Okay, great. So the second thing is that is detection bias a selection or is it an information bias? And well, you will find a very clear explanation about it in the article. But basically, as I said, it's all relative if you're looking at it from a case control perspective or from a cohort perspective. And that makes totally sense. Because, I mean, we are talking about how we are diagnosing the outcome, okay? So if my outcome or the disease is basically, when I'm talking about the case control, the outcome, it's how I'm selecting my participants, right? So disease are not disease, it's how I'm selecting. It's an early stage of a case control. I'm selecting disease versus non-disease, case versus control. So in this case, it's a detection bias. So the way, if I'm having a bias in how I'm detecting my outcome or the disease, if you want, it will be a selection bias because it will be related to how I'm selecting my participant. However, in a cohort study, I start with people with exposure and non-exposed, right? And then later on, I start and I will follow up the subject, and then I'll try to, progressively, I'll do some screening and to classify the subjects or to identify those who develop the disease or not. So in this case, if I have any kind of detection bias in how I detect the disease, it wouldn't be as a selection process. It would be later on. It would be when I'm at the level of information. So it will be an information bias. So that's the whole, it's just the approach. I mean, I have a bias in how I'm doing, how I'm detecting my outcome. If my outcome is basically how I'm selecting my subject, it will be a selection bias. If my outcome is not, it's basically in a cohort, it is an information that I'm collecting throughout my cohort, it will be an information bias. Does it make sense? If you want, this is another slide that I've taken from Dr. Shaya's course, just to show exactly what I'm saying. So when we talk about a case control, so we have type of study, case control and cohort. So when we talk about case control, the inclusion is it's on the basis of the outcome. So if I have any kind of detection in my outcome here, it will be a selection bias because my here. So because I have a detection bias regarding my outcomes, it will be a selection bias. But when I'm looking at the cohort, it's how I include my participant based on the exposure, which is the selection bias. But when I actually collect information about my income throughout my cohort, so any problem in the detection of my outcome would be an information bias. So it's just, if you want the approach, how you're looking at it. Is it clear?
Yes.
Okay. Anyway, it's very, very well explained in this article. They're just showing you the difference that both are the diagnostic suspicion bias. One, it's a selection bias when you talk about case control, and it's an information bias when you talk about cohort study. It's very well explained. This is like a plus, and it's like a detail, but because sometimes people get confused, they read about detection bias as a selection, and then they read about detection bias as an information, so they get lost. And I thought it would be nice just to clarify the idea that it can be both, but it's just to approach the perspective if you see it from a case control perspective or from a cohort perspective. Because I've been asked this question several times, and I thought it would be nice just for you as additional knowledge to know that the same bias can actually be labeled selection or information. Now, this is just very quickly when I'm going to give the example of detection bias in a cohort, which is basically an information bias. So very quickly, when we have a cohort, it's a knowledge of intervention or exposures that can influence assessment or reporting of the outcome. So this is when, as I said, if I know the exposure, it can influence the way I'm going to, for example, do a screening or to ask a question to my participants. So for example, physicians who were aware of the causal relationship between working in the rubber industry and bladder cancer might be influenced by this knowledge. So in that case, bladder cancer were understated for men working in other occupations. So this is in one of the studies. They showed that it was a cohort and the exposure was working in rubber industry, and the outcome was bladder cancer. And they found that physicians, when they knew, because they were not blind, that they knew that this participant was a worker in the rubber industry, they were more prone to, for example, to screenings, and whereas when the worker was not working in the rubber industry, they overlooked more, they were less thorough. And this is why they found an underestimation of people with bladder cancer among people who are not working in rubber industry. So so we have a misclassification of C to D. And in that case, the odds ratio would be overestimated. So it's the same principle, it's a detection bias, as a way we are detecting the outcome. But in this case, because we're talking about a cohort, it's the way we are collecting the information, and it's called an information bias. Or we can also call it a diagnostic surveillance bias. Is it clear?
Yes. I have a question.
Sure.
Can some of these biases be represented in DAGs like confounding? For example,
Yes.
going back to the example of estrogen and cervical cancer.
Yes, it is actually. All the bias can be represented as DAGs. That's totally correct. And selection bias are basically a subgroup of collider bias. I'm gonna show you one now because you asked about it. Okay. So what you said is completely correct. You can represent selection bias. In DAGs, you can represent selection bias. You can even represent information bias, but I'm not going to delve into it. It's another, if you want, it's a whole session. But just quickly, we know how to represent confounder with DAGs when we talk about common cause. When you talk about selection bias, the way to actually, it is a collider bias. So I'm just going to give the example of Bergson bias is one of the example of selection bias. And it's exactly the same that I gave you. So if you have locomotor disease can cause hospitalization, which is exposure. And my outcome, which is respiratory disease, can cause hospitalization. So what I'm doing, so here, if I look at the DAG as it is, okay, if we forget, if we just look at this, at the DAG, okay, so I have hospitalization is a collider, right? Because it is a common effect of the exposure and the outcome, or exposure outcome. You can take respiratory disease as exposure and locomotor disease as the outcome. Do you agree?
Yes, definitely.
And in this case, what I'm doing when I'm actually selecting people from the hospital, so it is as if I'm doing a restriction. So it's as if I'm conditioning on or adjusting for hospitalization because I'm just selecting people who are at the hospital. So I'm restricting you remember when we talk about confounding, we have several ways to adjust. It could be restriction, it could be matching, it could be multivariate regression. So one of them, as we said, it's restriction. And if I'm restricting all my sample to people at the hospital, it's as if I'm adjusting for it. Do you all agree?
Yes.
So in that case, because I'm adjusting for hospitalization, because I'm restricting our sample to people in the hospitals, what will happen when we adjust for a collider? It will create a spurious association between the exposure and the outcome. And this is why they got an odds ratio of 4 instead of 1, because basically they adjusted for hospitalization because they restrict their sample to hospital patient, and this is why they created this DAG, this fake association. So to answer your question, yes, you can represent selection bias as DAGs, but when we discussed it with Dr. Shai, we felt it would be better just to keep DAGs as, not to delve too much into this, and to keep DAGs more at the confounder. But it's good for you to know that collider bias, that selection bias is a subgroup of collider bias, that some collider bias can explain selection bias when basically the collider is the selection factor. So you are basically selecting based on the collider. Okay.
Okay, thank you.
So let's go back to, okay, so let's go back to where we were. So I think we finished everything related to selection bias. So we talked about the detections, the Bergson's incident. Cohort, I'm not going to go over them because I think you all know, you're familiar with loss to follow up. So when we have a cohort and you have the people who are basically leaving the cohort, but it's very important to know that the people who are leaving are different than the people who are staying in regards to exposure and outcome. So just for you to know, that doesn't mean that in all cohorts, we're going to have a loss to follow up. But the most important thing is, if the question that you should ask is whether the characteristic of people who are leaving the cohort is different than those who are staying in the cohort when it comes to the association, when it comes to exposure and outcome. If this is the case, it will create a bias indeed. Okay, so this is for the selection bias. So it's a whole concept in your mind that, so you have a different way to select your individual when it comes to the different, when it comes to case control or exposed or non-exposed. Now for information bias, it's easier, maybe I can say it's more common sense. It could be due to a measurement bias. If for example, my scale is not well calibrated. It could be, as we already said, reporting bias or social desirability bias, as I gave you the example of the alcohol. And one of the way to basically decrease social desirability bias is by doing self-reporting, self-reported questionnaires. So in this case, the subject would not feel pressure to answer like the interviewer wants. They will feel more comfortable to give the honest answers. An interviewer bias, I also gave you the example of interviewer bias when we're not blinded, when the interviewer is not blinded and he knows that the subject has the exposure, he might be more prone to probe the questions differently for exposure and unexposed. Case control, we have recall bias. As you said, it's also in cross-sectional, but basically recall bias is, for example, when you talk about women with babies with malformation, congenital malformation, and you want to, so my exposure would be drugs or antidepressant drugs, and my outcome would be congenital malformation. And I do a case control study. So I select mothers, and it will be obvious. I mean, several articles have shown that mothers of babies with congenital malformation have more tendency to remember all the tiny details and everything and all the drugs they have taken, whereas mothers of babies who are healthy are more tendency to forget. So the recall bias, important thing is to know that it's a different way to recall when it comes to the exposure and to, for example, case and control. And this is different than poor recall. So these are two concepts that are usually people tend to mix them up, but it's two different concepts. So when we talk about recall bias, it means that we have a different bias, a different recall between cases and control. So in this case, the example that I gave you, cases remember better than control. But when we talk about poor recall, it could be across all your population. I mean, across all your subjects. So for example, they all don't really remember when we talk about, for example, diversity questionnaire, they all don't remember what they ate last week, So that's a poor recall. It's different than a recall bias. And exposure suspicion bias, it's a form of recall bias. So when, for example, as I told you, if a woman has a baby with congenital malformation, she has tendency to maybe, remember more all the tiny details when she was pregnant. And she might also tend to think that maybe I've taken this off, maybe I've been subject to this pollution that could have led to to the fact that my baby now has malformation. So if you want, it is the fact that the subject know that she has a disease, she starts being more prone to remember all the tiny exposure or potential exposures that she had. And this is what also we call exposure suspicion bias. But if you want, it's like recall bias. It's exactly the same concept. It's just like another labeling. And finally, detection bias for cohort. I already give you the example when we talk about the bladder cancer and the rubber workers. Okay, is it clear so far? Yes. Okay. Yes. So finally, just to continue the slide about the different systematic error and how to minimize it. So we talked about random error, and to minimize it, we have to increase the sample size. We talked about confounding bias. You already know how to decrease them. So let's go to measurement bias. So we talked about observer or interviewer bias, recall bias, reporting bias or social desirability bias, surveillance bias or detection bias. And in your opinion, what are the methods that we can do to decrease measurement bias? How can I decrease information bias? I mean, if I'm talking, I gave you one example about the social desirability bias. It's basically to give self-report.
We can train interviewers to do the interview in a certain way, in a standard way.
Yes, perfect. Perfect, that's correct. To do standardization.
Well, we don't ask questions about things that happened a long time ago, recent stuff to
Yes,
reduce
we
recall.
can. Yes, we can try to find methods to assess our exposure that doesn't really, I mean, sometimes you don't have a choice, but if we have a choice, yes, exactly. We have to use, as you said, also scales that are validated, calibrated also for the measurements, for example.
Also, we can collect information about the exposure from several sources.
Yes, perfect, yes. And also you remember when I talked about the interviewer bias, so the people who know if the subject is exposed or not exposed. So how can I actually solve this to avoid interviewer bias?
We do a blinded interview, yeah.
Yes, to blind the interviewer. So the interviewer don't know, yes. So the subjects, for example, if I'm doing questionnaire, I'm administering the questionnaire. I don't know if the subject in front of me is exposed or not exposed, or if it's a case or control. Perfect. So these are the methods. And now for selection bias, it's way more complicated to decrease selection bias. You have to know it's really more challenging than measurement bias. We talked about the Bergson bias if we have hospital patient, attrition or loss to follow-up bias, Neyman's bias, or incident prevalent case bias. This is ascertainment bias or detection bias, volunteer bias, and non-response bias. In your opinion, how can I actually decrease the selection bias?
For me, I have a question about, for example, considering the sample size, if we manipulate it or if we didn't get the precise or the accurate sample size, do we consider it selection bias also?
You mean a sample size? No. No,
maybe sometimes in calculating the sample size, some people manipulate for example, in calculating you have to calculate the exposure and the proportions. They manipulate it in order to have this number or that number.
Okay, I see what you mean.
We
yes,
took
but
this
is
in
of course
RCTs.
Not a bias. This is not a bias. This is even unethical. This is completely the whole. It is related to type 1 and type 2 error. So of course, manipulating sample size is unethical, and it will lead to type 1 and type 2, and it will actually affect type 1 and type 2 error. In selection bias, it's different. It's not about the number. It's about, if you want, the characteristic of the study population. It's not how much, it is actually the proportion, the probability to select, so that actually your sample is representative of the target sample. It is not about the number per se. You know what I mean?
Yes.
So your question about, yes, if we manipulate for the sample size, it's definitely unethical, and it definitely will affect the power and the type 1 and the type 2 error. But for selection bias, if I want to minimize it, it's very challenging. But if I want to minimize it, I'm just going to give an example. For example,
can do randomization?
Yes, perfect. Yes, we can do randomization. Yes, great. That's one option. Try, for example, when we talk about volunteer bias, so try actually to avoid conducting studies with volunteering, especially if I know that people who are volunteering have in their characteristics something that is related to my exposure or my outcome. What also I can do for non-response bias is try to collect the information of people who are who refuse to participate, or for example, loss to follow up. I can try to collect the information of people who don't want to continue in my study, and this is a way I can basically compare the characteristic of people who are leaving the study or people who are not accepting to participate in my study, and try to do some weighing later on in the analysis. Now, of course, when you talk about selection bias, the first thing that you have to do from study design is as much as possible to decrease for example, loss to follow-up, you have as much as possible try to decrease people to decrease the percentage of people who are leaving the study. By doing, you have several ways you can do to motivate them to stay in the cohort, to give them always a reminder, to have several ways to be able to reach them, as much as possible to try to minimize losing people in a cohort. But let's say we're going to have some loss to follow-up. What we could do is to try to retrieve from the people who decided to stop the study, to retrieve some characteristics and that are related to my exposure and my outcome, and try to compare it with those who stayed in my study. And that would help me later on in the analysis to try to find if I can do some kind of weighing. And another way is also, so this is also in the article that I've shared with you. We can do some oversampling. For example, I know that there is a group who, let's say I'm talking about schools in Lebanon. I want to recruit children from private and public schools, but I do know that public schools are more reluctant to participate. So I will have a very high non-response among public schools. So in this case, a way to overcome this is to oversample public schools to be able to have a representative, to be able to actually reach the selection probability of the target number that I want. But here I'm not talking about sample size. Yes, I'm talking about characteristic because I want to have people from the public schools, not just from the private schools, not just from the public schools. So this is different than increased sample size. Okay, this is just to make sure that among my population, I don't only have private, I don't only have public schools, I also have private schools. So I try to increase to oversample private schools to be able to have to be able to have enough variability in my sample. Okay, but this is not about if you want the number, absolute number. It's about having enough of private and public. If private and public was my exposure, let's say. Okay, I know it could be a little bit confusing, but just to keep in mind, the selection bias is way more difficult to decrease or to control for it as compared to measurement bias or confounding bias, because it's at the very early stage of the study design. And the best way is basically to try as much as possible to avoid having the bias. But once the bias is here, it's more difficult to decrease it. Okay. Is it clear?
Yes.
Okay. Now the last thing before the last concept is just about the difference when you talk about differential versus non-differential misclassification. So, do you know what is a non-differential misclassification bias? So this is formation bias. We have misclassification bias. So when we talk about misclassification bias, there is a concept called differential and non-differential misclassification bias. Do you know what is the difference between them? Can someone tell me?
The non-differential misclassification actually does not affect the association itself, and it happens equally across all groups, the exposure, the exposed and non-exposed, or diseased, non-diseased.
Yes.
And and the most important thing is that it does not affect the the association between the outcome and the exposure.
You mean it doesn't affect the association, or you mean that it will be toward the null?
No, it will not be toward the null. It will not affect the association.
It will not affect. Okay. Yes. And do you all agree with this?
No, I think it masks the association.
It masks the association. And what about differential misclassification bias?
It overestimates the association between. One of them overestimates the association, and one of them masks the association.
Okay. Do you all agree, or do you have other suggestions?
I think non-differential won't have an effect on the association because maybe it's proportional among all the groups, as Nihad said.
Okay. So let's see, let's discover together. So non-differential misclassification, as you all said, it's correct. It's when the misclassification is the same across the groups to be compared. So for example, exposure is equally misclassified in cases and controls. So it could be non-differential misclassification of disease. So in that case, the misclassification of disease do not differ by exposure. So I have, so my disease is basically misclassified, but it is just equally across exposed and unexposed. And we have the non-differential misclassification of exposure is when the misclassification of exposure do not differ by disease. So it's basically equally misclassified between cases and control. And differential misclassification, as you all said, it's when misclassification is different in the group to be compared. For example, in a case control study, the recorded exposure is not the same for cases and control. So we have a misclassification, but in that case, it's not equally between, let's say, case and control. Same thing, it could be for disease or exposure. So we agree about the definition of differential and not differential. Now, the direction. What we have to know that in non-differential, usually we say that the estimate is biased toward the null value. So in other words, this is also an example from Dr. Shaya's course, just to illustrate differential and non-differential and how it can change the odds ratio. So let's say that my exposure is dietary fat. I have food frequency questionnaire that I administer to my students or to my subjects. And at the end, I did a score and I categorize them as high dietary fat intake and low dietary fat intake. And the second, my outcome is myocardial infarction. So we have present and absent. So it's a case control. So I have cases with myocardial infarction and I have control without. The truth, so when I do my odds ratio, this is the truth. Okay, it's ideal because in reality, you can never know the truth. But let's say this is an ideal, or this is a hypothetical scenario that I know the truth. And the truth would be that the odds ratio is 2.25. Okay, so basically that a high dietary fat would increase myocardial infarction by 2.25. The odds, right? If I have a non-differential misclassification, which means here, for example, that 20% in the high fat, so in my exposure, is classified as low in both cases and control. So it's exactly the same percentage, which is 20%, that will be misclassified in cases and controlled from high to low. So this is what we call a non-differential misclassification, because we do have a misclassification from high to low, so from exposed to non-exposed, but it's exactly the same between cases and control. In this case, the odds ratio would be equal to 1.96. So it's not the same than the truth, because we did have a difference in the numbers. It's not the same. But in generally, if you can see, it is toward the null. Okay, so the null here, it's 1, because odds ratio, the null is 1. And usually, because it's toward the null, some researcher would say it's not that critical. I mean, it is, I'm going anyway to talk about it, that it is still critical because non-differential misclassification is not always toward the null. But before, some researcher would say that it's not as critical as differential misclassification because your odds ratio would be toward the null. So it is as if you are not, so it's not as, if you want, dangerous quotation than to basically overestimate the odds ratio. It is more like it's more under the toward the null, so it is not going to be such a big a deal. This is what before researcher would basically argue, and this is why we used to say that differential misclassification is a little bit more problematic than non-differential misclassification. Now, a differential misclassification, what does it mean? As you just said, is when we have a misclassification from one group to another group, so here from high fat to low fat, but it is different between case and control. It's not the same between case and control. So for example, here we have it also 20% in the high fat that is misclassified as low, but it's just in the control group. So we don't have it in the case. So this is a differential misclassification because it's just among the controls. In this case, the odds ratio would be equal to 3.2. So also it is an odds ratio that is different than the truth. It's not like the truth, but in this case, you have an overestimation because it's 3.2. It's as if it's a more bold, if you want, conclusion. And this is basically why we usually say that the general rule would be that differential misclassification of either exposure or disease will bias my estimate. It could be either toward the null or away from the null, but most of the time, sometimes, and it could be away from the null, and which can really be problematic. So differential misclassification can go both direction, but because it can go away from the null, so it can, if you want, overestimate your effect estimate, it is quite problematic. And non-differential misstratification of both exposure and disease, I'm going here to say in general, the bias is always toward the null. So it will, if you want, attenuate your association, which is not as problematic as the other case. However, I said here in general, because more and more people are saying that we have exceptions. And for example, if you have here, we're talking about two categories, right? We're talking about low, high and low fat. But researchers are saying that if you have more than two categories, the rule may not hold that if you have non-differential classification, it will be biased towards the null. And I would definitely advise you to read this article. So this article is very recent. It was March 2022, so it just got published. And it's an article talking about the misconception about misclassification, that non-differential misclassification does not always bias result toward the null. So this myth that, it's okay if it's non-differential misclassification because it will attenuate your odds ratio, but it wouldn't it's less problematic than an overestimation is not completely correct. Okay, that's it. I think we can stop here. So this is like a very quick overview of biases, just the difference between selection, information, confounding, differential and non-differential when we talk about information bias. Do you have, this is it was a very quick overview. Do you have any question about it?
Dr. Yeah, I do.
Yeah, sure.
And the non-differential, for example, if the misclassification happened from the from the non-exposure group to the exposure group.
Yes.
Vice versa of the example we had in this case.
Yes.
The one to the left. Yeah, but from low to high, not from high to.
Yes.
Yeah, so it will be I think we'll have overestimation, right?
No, I don't think so. You can try it. But no, I don't think so. You will have it toward the null. We can try it.
Okay.
Yes.
Okay, I will try it.
Yes, if you want to try to have bad شوي وقت, you can try it, but no, it should be toward the null.
Okay. I will try it and I will check it.
So let's do, if you want to do the opposite, so 20% from low to high. Okay. Another question. How do you feel about bias? Do you feel it's a complicated concept? Do you feel it's clear?
It's clear. It's not complicated. But when we took the example regarding the non-differential bias in the previous courses, it was not the same as you illustrated here, because here you said that 20% from the high, yes, 20% from the high fat, they will go to the low. So I recall from the example that we took with Dr. Ghandour is that we subtracted 20% equally
from the low. Okay.
From the high and the low, and that's why I remember that the odds ratio did not change, and that's why. But here, when I looked into it, no.
No,
we took
this-
20% from the high and we add them to the low.
You added them to the low.
But
Yeah,
that
here.
was in selection bias, differential and non-differential selection bias. When it's not non-differential, the odds ratio does not change. But in classification bias, it changes.
Oh, yes.
So yes, here I'm okay. So here شوية أطش عنده, but here it's an example of an information bias. If we have, so we misclassified, yes. So we have the subject, instead of being in the high, we put them in the low.
Oh, okay, okay, yes. Makes sense.
Okay. But as I told you, the thing that a non-differential misclassification is not always biased toward the null. It's something that is quite recent, so not everyone is really talking about it. If you want, I mean, even this article, if you can see, it's just like it's very recent. It's 2022.
If I may, is that usually non-differential is not that harmful. Okay. Even the one, the drop from 225 to 1.96 is a change, but it's not a harmful change. So even if it's not published as an article, we're not very concerned about non-differential as much as the differential bias, right?
Yes.
So, but what Nihad is talking about is not information bias, but selection bias.
Okay, I see. No, here I'm just giving here the example for classification, information bias. Yes.
Would you have time for application, or are you going to continue? Because you have only 15 minutes.
Yes.
Some students have another class. So
yes. So I think yes.
Since you did not take any break, so are you going to do anything?
Yes. No, I think what we're gonna do. I'm going just to post an article on the Moodle with question and answers. So you can basically, if you want later on, you can look at the article and how I actually do the critique of the methods. It's just like one article with the methods. You don't need to read all the article. And I'm going just to write what are the threat to validity. So what are the potential biases that we can find. Is it a non-response bias? Is it Bergson bias, etc.? So it could be for you an application for later on if you want to see, illustration with real articles from the literature. I can actually do this with 2 articles. So I would post 2 articles and I would put the key solution if you want. So what
Please don't put the key solution now. So let's allow them some time to look at the article and read it, and then within a week time you can unhide the solution. Please just let's have a key, please, if you have.
Okay. Yes, sure.
Anna, if allow me, I need to leave.
Yes.
Thank you really so much. It's been great. Just a quick note that I'm trying to convert the application and the lecture into a video. I was not able to do that alone. I've asked some support from IT. So once I do that, I will share them with you all, okay? Or I'll share the link to the article and the application session, okay? Thank you so much, Christelle.
You're welcome. Me too. And please, if anyone has any question really, especially biases or tags, don't hesitate to email me asking anything really. I would be more than happy.
Thank you so much.
Thank you so much, Christelle. Thank you so much.
Thank you.